Hello and welcome back to Conceptual OBG. And I'm welcoming you all to a very, very important session. And I believe this session is important not just for postgraduates, but definitely for undergraduates. It's an exam question for you all. It is also an important question for all the consultants. So I have made this session in such a way that it benefits all these three different hierarchies of doctors, and this session will make it extremely easy for you to remember each and every 2021 guideline wala, every single parameter and the logic behind it. So until I did my fellowship, I had this habit, and I would be very honest, it was even through my residency, I had this very unfortunate habit of just mugging up the WHO semen analysis values. And that helped me in my undergraduation, that helped me in my post graduation. But again, it was a very theoretical way of understanding the topic. And it didn't really make sense because if I wanted to do something for a patient, those values would not help me. So once I kept reading more and more into it, and after my fellowship, I got a bit more insight. And I believe this session is a culmination of whatever my experience has been with regards to whatever I have read from Gartner, from Kamini Rao, and from several various sources. And fair enough to say that the next, I don't know, maybe 2 hours or 1.5, 2 hours are going to be very crucial. I would like to give you all a disclaimer that there is an attrition rate. Attrition is basically the number of people who leave a job at hand or a task at hand. There is often an attrition rate of around 20% or 25% after the midway point. Do not do that. Do not leave this session midway through. I cannot guarantee. I have only kept it on YouTube because that limit of I wanted that limit of 150 to not be there to the room so that everyone can attend it live. But I cannot guarantee if it will be available after this as well. Because this is a session under the ART segment of Conceptual OBG, this is the 13th session in that. So we might archive this into our app directly, exclusively for the subscribers. So I would request you all to attend this live and trust me on this part that every single point in this lecture is going to be meaningful, is going to carry a lot of logic, physiological logic behind it. And at the midway point, like a movie, it is going to start making even more sense. So there are so many examples and so many pictures and everything that are going to start from the midway point, and everything that you learn in the first half of this movie, I would say, of 2 hours, is going to start making sense even more and will start correlating even more in the second half. So do not leave, because if you leave, I do believe that even the first half is going to be a wasted thing. So welcome to the session, and let's begin. The reason I spoke a bit was I was actually waiting for all the students, more and more people to log in so that we can have this 2 to 3 minutes, 2 to 3 minutes delay. Secondly, whoever has a doubt can ask me in the comments. I'll be answering it live. And yeah, whoever wants to access all these sessions, uh, do log in to Conceptual. All these fellowships cost what, 3, 4 lakhs or even more. This is giving you literally an access to understanding whatever I have learned there, and with the best practices and everything that you can incorporate in your practice if you do not have the time and the money to go and join any of these fellowships. It is also very useful for those who want to do fetal medicine, because we have a full-fledged fetal medicine course. So do join. And I get a very common complaint, or not a complaint, a request that they want just the SS segment. Remember, we are not yet separating out the SS segment from the core OBGY subjects, because a lot of students who are preparing during the residency also want to learn the subject of super specialty that they would love to practice aage jaake. So that residency is a period when they start realizing what is their liking, which subspecialty would they want to practice. So we have kept it together. That is a major reason, and we have not separated. But despite that, the rate is still the same, and it is quite reasonable. If you go and inquire about all the online just fetal medicine, exclusive fetal medicine classes, they cost around 1.2, 1.3 lakh. So all these things, you have to understand that is going to help you a lot. And let's begin with this session. So let us just get warmed up to the understanding of what semen analysis is. So when semen analysis was first done by WHO, it was in the 1980s. And it got multiple revisions. What I was learning until my undergraduation was the WHO 2010 values. And most of the consultants here must have also learned this in their learning period right now, whoever is watching this. This was the fifth edition of the original 1980s WHO. By the way, I've gotten a request to speak in English exclusively so that people who are not from India can also understand. So I'll make sure I'll try my best to not get into the flow and slip a bit of Hindi in. I hope that is okay with you all. And if you all are able to hear me, if I'm audible, if there is no issue, please comment below if I'm audible enough. If you can watch my, if you can see my screen. I hope you can see that. Yeah. So this did, and there was a very significant problem in this. The problem was that they had defined the lower fifth percentile. But the problem was we started seeing that even patients or males who were having their semen parameters below the fifth percentile. Now, what is the meaning of percentile? So imagine I have 100 people who I'm studying. So whatever the values are for the lowermost five people on the basis of the counts and motility and morphology and everything, they are going to be the lower fifth percentile, whereas the ones of the highest would be the top 5 percentile. So when I say the lower 5 percentile, it indicates the people who have the least parameters. So it was being seen that for patients who even had values less than fifth percentile, they were still conceiving and they were not really infertile. So it was understood that its fertility, male fertility, is a very dynamic concept, and merely the presence of one or two factors out of the several that we are going to be studying today, the presence of that in inadequate proportion is not good enough a reason to call these patients infertile. So it was decided that first of all, the biggest problem of this 2010 uh, edition was also that it was only studied in Caucasians. So it was decided that they would want to study a lot more people. So WHO in 2021 studied more than 3,400 patients. They studied male fertile patients. And not just that, these were from these were from 12 countries and 5 continents. So this was actually a semen analysis that represented a bigger population because, of course, not two people who are living in two different countries in two different continents who are exposed to different environmental factors are going to have the same parameters. So it consisted of a generalized population that they studied. And when they did that, they changed a few things. The first thing that they changed, the first change I'm writing in green because these were all positive changes, was that they abandoned the concept of fifth percentile or lower fifth percentile. Instead, they adopted a normal range. Although they have given values for that percentile, but they have said that you cannot be calling that as a diagnostic factor or a diagnostic criteria for infertility. Plus, you will have a normal range which will encompass the patients who fall even below the fifth percentile. I'll be showing you the normal range for each and every parameter. But this is one of the first things that they decided. This led to a lot lesser patient, not lot lesser, fewer patients being diagnosed as infertile or subfertile. The next thing that they did was they reverted back to 4 classes of motility, which included rapidly progressive, slowly progressive, non-progressive, and immotile. So these are the 4 classes. In 2010, there were only 3 classes. So they decided to revert back to 4 classes. So the 4 classes were A, I will teaching you this later, C and D. Apart from that, they also said that do not stop the counting of sperms if the value is below 2 million per ml. So earlier, if the value was less than 2 million per ml, the labs would just report it that way and they would not count it further. Now they have said that you have to report lesser concentration, lesser numbers as well, because those lesser numbers can still be invaluable because I now will be relying on ICSI and IVF. So that is why even if it is, let's say, 1 million, 0.5 million, you have to report it in your semen analysis report. This was another very big change. One more thing is they included not just these criteria of morphology, motility, sperm count, vitality. They also said, let's be more inclusive to other factors like sperm DNA fragmentation or oxidative stress. So they were much more inclusive about even the damages that were not seen under the microscope or with the naked eye. That was damage to the DNA, which was very, very significant a change. And lastly, they upgraded the morphology criteria, which is also called as the Kruger's criteria. Strict Kruger criteria. What it is, I'll come to each one of it. But these were few of the, not few, these are the major changes that have happened in the 2021 WHO report. Now, what exactly were these changes? I'll tell you that. But before that, we need to know that before I get the sperm in my lab for testing it under the microscope or for examination with my naked eye, it has to undergo or it has to fulfill a few prerequisites. So what are those prerequisites? So these were called as the pre-testing prerequisites. Basically, these prerequisites have to be fulfilled before you process it, because if these are not fulfilled, it is futile and it is going to give you a falsely positive or a falsely negative report. So what were those testing prerequisites? So the first very important testing prerequisite was that there has to be 2 days of abstinence from ejaculation. That ejaculation can be in the form of sexual activity like coitus, or it can even be in the form of maturation. So it has to be exactly 2 days. Especially if it is less than 2 days, then how is it going to reflect in case it is less than 2 days? Let's say the abstinence was only for 1 day. So the biggest problem is going to be the volume that you get is going to be lesser. Lesser volume, apart from that, the counts are also going to be lesser. But the good part is going to be it is going to have a little bit more of progressive motility. Why? Because lesser days of abstinence or lesser time of abstinence or between two activities of ejaculation means that the sperm is staying in the epididymis for a lot lesser time. Now, epididymis is that place. I'm going to be talking about epididymis. I have mentioned that at the halfway point, I'm going to be discussing a lot of amazing concepts. This is one of them. That what exactly happens to the sperm inside the epididymis. It's a very important concept, and I'll be talking about it when I come to motility. Do not miss that part. It is very important for you all to know. All we know is it attains maturity. But what exactly is maturity? And if it attains maturity, then why do we say that for it to stay inside the epididymis for anything longer than 2 days is a problematic thing? We should know the reason. Why is it a problem? So, because it stays anything, or if it stays lesser in the epididymis, its motility is going to be much higher, which is in fact a good thing. So this is one good thing about less abstinence, but the overall volume and count is going to be lesser. If it is more than 7 days, which is extremely high, then everything opposite is going to be seen. It is going to be much more in volume, but it is also going to be a lot less viscous. Apart from that, the counts will also be high, but the counts will also include dead sperms, because of over maturation, there is going to be senescence or necrosis, which is also why we call it as necrosospermia. So dead sperms are going to increase if the period of abstinence has been too long, and the motility is going to go down drastically. And to add to it, there is going to be higher sperm DNA fragmentation. I'll be discussing this as well in detail today. So these are all the problems that are going to be seen if the abstinence period is not maintained, which has to be 48 hours. A few practitioners wanted to do, but I do not agree with that. I do not follow it, but their experience has helped them. So up to them. What they do is, if the period of abstinence was too long, they ask the patient to masturbate. They take that sample, they do study it, but they also tell him, or of course, they tell that person to masturbate again after 1 to 2 hours and give that sample as well. So what happens is the next sample, the second sample, is going to have lesser volume and lesser count, but it is going to have better quality sperm. It is going to have more motile sperms. It is going to have less sperm DNA fragmented sperms. So good quality sperms can be obtained for ICSI from that second sample. So it is another way of tackling this issue. I don't do it much, but this is one thing. I mean, I just ensure that they have been informed about having an adequate only of 2 days abstinence period. Next is going to be, this was the first prerequisite, that is abstinence. The second one is about collection. The collection has to be done in a wide mouth, tight and screwing type of container. Wide mouth, why? Because whenever a man is ejaculating, the first contains maximum amount of sperms. It contains the best quality sperms as well. It is very rich in that. And if it is not a wide mouth, when he or she, not of course not she, when he is ejaculating, if he is not able to place it perfectly inside that container, the first few drops might just spill down. That is wastage of good quality sperm, which is why it should be a wide mouth, big, tight screwing, so that whenever, if there is upar niche kuch hua, basically if there is any upturning of the container, it should not spill out. It's a liquid after all, it should not spill out. So that is another point. And once this is done, of course, it has to be sterile. It cannot be something that has been opened before, because then the microbes will destroy microbes with all the oxidative damage they will do the oxidative damage to these sperms. So you do not want that. So it has to be tight, it has to be sterile, the packet has to be opened by the person in that room itself, and very importantly, it has to be done at the center. So at the center, they are given a room. Now I remember at the place where I did my fellowship at Dr. Nadkarni's, Dr. Kishore Nadkarni sir, the senior one, who was instrumental in starting that center, told us that the ART laws have certain directives. I mean, they have provided directives for how should that semen collection room be. So it should be a comfortable room. There should be a bed. Preferably, there should be an AC. Why? Because it has been shown that a man, when stimulated better or in a better frame of mind, gives much better quality sperms. Whereas a man who is not well stimulated, who is struggling a lot to get an orgasm, is going to give a very poor quality semen. It has been seen multiple times. And that is why what they would do is they would provide magazines and all. Of course, now you do understand what kind of magazines would be provided. Those magazines were being provided and men were doing it, but eventually they started noticing that the magazines are disappearing. So it became very obvious that men who had actually come there to impregnate their wives were also stealing those magazines which had other women in it. They had to stop doing that and they had to tell them that please bring your own content, be it on your phone or something. In fact, if the man is struggling to do it because it's a new space, it's a new area, they can also, and they have to also provide the couple a room so that they can have coital activity in that room comfortably. It has to be a private room, of course, and the man can wear a non-spermicidal condom wherein it is going to be collected inside that. Of course, this is an inferior way because latex or any polyurethane condom is not the best of materials to keep sperms in, but this is another way that they can induce a man to get his ejaculate. Very important to note that, and these things have to be done. You will see in a lot of centers, those special rooms and everything have to be kept very clean. They have to have that AC. The man has to be very comfortable to get good quality sperms. So important. And if the man is still uncomfortable to do it at the center, then if he is doing it at home, then he has to get it within 60 minutes. And the temperature that he has to maintain is between 20 to 37 degrees Celsius. A lot of times they tell to hold it below your arm and bring it. And it is basically room temperature maintained करना है तुम लोग को. You don't have to let it exceed that temperature. So, but again, it's the collection at home is an inferior method. The third is the timing after analysis. I mean, the timing for analysis. So, after the semen has reached the lab, within 60 minutes, you have to, from the point of collection till the liquefaction has been started. So, what we do is when we get the semen, so this semen contains, now this is a very important physiological part which I am going to come to, but I'll just give you a hint. So the seminal vesicle secretes something called as seminogelin. This seminogelin is something that forms a coagulum. What's a coagulum? Coagulum is basically a coagulate. It forms clumps of the semen that is collected. Now this clump is going to be broken down by something called as the prostate specific antigen. Yes, it is the same antigen that you test for in elderly males for benign prostatic hyperplasia or even for prostatic cancer. So, what is the actual use of this PSA is not to diagnose these things, but to cleave these seminogelins and to liquefy it. What is the use or what is the reason this exists? This is because whenever the semen is deposited in the female vagina, which is acidic in nature, this acid can destroy those sperms because those sperms are used to living in an alkaline environment. That alkaline environment is created by the seminal vesicle. So as to prevent this destruction, evolution has ensured that the seminal vesicles also give with it a protective coating of coagulum formation so that the acid is not able to destroy that semen. But once the same semen reaches the cervix or in the uterus, the prostate specific antigen, which is also present in that semen, will start acting and it will start releasing it or it will start natural liquefaction. Now, this liquefaction cannot occur in this setup. So, what do we do? I mean, it cannot just occur because there is no uterus. So, what do we do? So, what we do is at slight temperature of 35, 36 degrees and in CO2 incubator, CO2 why to mimic the vaginal conditions. So, acidic environment has to be mimicked. So, this acidic environment is going to be mimicked by keeping it in a CO2 chamber and we keep it there for 30 minutes. When you keep it there for 30 minutes, by itself it will start liquefying. If it doesn't liquefy, we can even add chymotrypsin and bromelain. That is another option. But this is very important. So we keep it for 30 minutes and then we start processing it. Why don't we directly process it? The reason is we do not want to process the coagulum because the coagulum will have all the sperms clumped together, which is very difficult to evaluate. And that clumping will also give us falsely low values of sperm counts. Hence, the timing of testing has to be 60 minutes because after it arrives to me, I have to also keep it for liquefaction. And if this time only of the semen arrival is more than 60 minutes, then the liquefaction gets pushed even further and the sperms are dying. I do not want it. So very important that it has to be within 60 minutes. Ideally, best is going to be immediately you collect it and give it to them. Next is going to be, of course, I have mentioned temperature. You have to avoid high temperatures and you have to also avoid fluctuations. So you do not want fluctuations. So one of the wrong things that you can do is to bring the semen in an ice pack. Do not do that. It will destroy the sperm. You do not want to bring it in ice pack. Lastly, very important point is you have to mention if you have taken any medicine or had any illnesses in the past 3 months. Why 3 months? Because 75 days is the time period for spermatogenesis. So you would say then it is 2.5 months. Why three? Because the remaining 15 days, the 75 days are the testicular spermatogenesis or spermiogenesis, whatever you call it. Whereas the next 15 days are spent in the epididymal region for maturation. So this is very important. So overall 3 months, the sperm is going to be in that body of that man. If that person has taken any medicines like especially beta blockers or testosterone related drugs or anabolic steroids or any chemotherapy, radiotherapy, sulfasalazine, colchicine, all these things that can make a difference in the DNA, that can cause DNA changes, steroid hormones, of course. Then in that scenario, chemotherapy, which is toxic, DNA toxic, these will lead to sperm differentiation, sperm fragmentation errors, and this hence it's very important that it will give me poor quality sperm. So even if I'm going to do ICSI or IVF, the embryo will be of poor quality and it will not implant or it will not progress only to the blastocyst phase. Hence, the sperm has to be of good quality. And hence, in the last 3 months, the patient should not have had any episode of acute fever or any major illness or any of the drugs that have to be consumed. If there is a history, then I would tell them wait for 2 months, wait for 3 months rather from that last episode, and then come back to me and then I'll collect your sample because it's a very natural way of your sperms for recovering itself so that I do not have to do anything from outside. Hence, these are all the prerequisites for testing. Has everyone understood everything that I have spoken until you quickly tell me? I absolutely hate an audience that is not responsive enough to ऐसा पीछे बैठ के देख रहा है. That is genuine mediocrity. Tell me quickly if everyone is understanding this in the comments. If not, I will be answering your questions quickly. Do not ask me questions for the topic that is yet to come. I am going to answer everything. वो सब end में, I mean, हिंदी वापस. Ask that in the end. Until here, is there any doubt? Is everyone understanding these points? Quickly tell me. So now, now that we come to the WHO actual WHO semen analysis, but before I get there, I have to answer a very simple question. Once I'm done with the testing of this, are there any indications for retesting it? A lot of people I have seen reorder semen analysis. Then there are a few indications in which you have to redo it. I would just want to address this before I talk about the main thing because once the main thing begins, the discussion begins, all these small things will be a little too far from the topic. So the first thing is going to be if the first one was abnormal report. Now, practically, just one report in a private setup is what I would like to, consider good enough. Yes, people do repeat it, a few people, but commercially, that's not a very viable thing. The patient will probably go away. But in your exams, you have to mention that you have to do a second sample if the first is abnormal, and that second has to be done after 2 to 4 weeks. What are the indications exactly? I mean, what do I mean by abnormal? So, first of all, if there is azoospermia or severe oligospermia, or if I have a cryptozoospermia, basically only after centrifugation is what I'm finding a few sperms. Uh, or if there has been any acute illness, as I mentioned earlier, in the last 3 months, or if the patient has undergone vasectomy, so just to confirm after 3 months. So these are a very few indications when I have to repeat. So basically, you just remember that if the first is abnormal, on paper, theoretically, you have to answer that I will be repeating it after 2 to 4 weeks. Commercially, not many people do that unless you are giving the patient some intervention like antioxidants, HCG, stimulation to the ovaries, all of these things, then it makes sense. But if not, just start with the treatment. Commercially, it's a wise thing to do. Now, what are the various parameters that are available? So these are the reference values. You would think so much to remember. Itna sab ratna hai kya? Do I have to mug everything up? Not really. I'll be giving you all a way. Just remember a few things. WHO 2021 reference values are fifth percentile values of fertile men. These are not diagnostic thresholds. So it means that a man above fifth percentile can still be infertile, whereas a man below one value can still achieve natural conception. So these values basically show a minimal acceptable baseline. So it's a minimal what is required, and hence it has to be understood that there is always going to be a proper range that is going to be given. Now, these are all the parameters. You can take a screenshot of this. The first value that they have given over here, just to understand how I have compiled this. So, this you won't find anywhere. This is something that I have made using AI and I have given certain prompts to make sure that you get this as a comparison. So, basically, the comparison is WHO 2021 versus WHO 2010. So the parameter is given first. After that, you have your latest 2021 percentile or the 2021 value. The 2010 is given after that. You see, this is the 2010 value in pink. And next is going to be what is the IVF consultant's thinking? What is the concerning value? What is optimal? So in everything, I have given it in this parameter. So there are parameter names, WHO values, 2010, the earlier values, and from IVF consultant's perspective, what would make a difference? Now, I wouldn't want you all to remember all this because I'm going to tell you all a very smart way of remembering it, and that is to understand each and every concept. So, so I have to keep on checking if the voice is okay. Hmm. So whenever we are doing these values, there are two major classifications. First are macroscopic values. So macroscopic values are those values for which I do not need a microscope. I can just look at it and I can tell a value for it. Whereas the others are strictly microscopic, which cannot be seen with the naked eye. So under macroscopic, I have things like semen volume, then pH, of course, because I can just dip in a paper of pH and I can see that. Apart from that, the color and the odor of the semen sample and liquefaction and viscosity. So liquefaction time and viscosity. These are all the macroscopic parameters which need to be remembered. So four macroscopic, and when I'm talking about the microscopic values, the first is going to be concentration and count. The next is going to be motility. Now we have a new value that is going to be a combination of all this, which is going to be called as total motile sperm count. So basically, total motile sperm count is the culmination of the concentration or multiplication of the motility, concentration, and quantity. So basically, it's a combination of these three factors. Very important and a much more sensitive parameter for diagnosing infertility. Apart from that, I have of course gotten morphology. Along with morphology, I also have leukocytospermia, basically the presence of WBCs and antibodies, anti-sperm antibodies. So these are all the microscopic criteria that you have to remember. So again, technically four things over here: concentration and count, motility, morphology, and leukocytosis. Four here, four there. Very simple. Now let's first talk about the macroscopic parameters. So in macroscopic parameters, the first one is going to be very important: semen volume. So in semen volume, the fifth percentile has been set to be, or I would say the normal is set to be above 1.4 ml. And the normal range has been set to be between 1.4 to 6 ml. If it is less than that, it is called as hypospermia. It is not azoospermia or oligospermia, that is lack of sperm count. Oligospermia, azoospermia is a microscopic finding. Hypospermia, hypo is like hypomenorrhea. Hypomenorrhea क्या होता है? Reduction in the volume. So hypo is less in volume of your semen, whereas if it is more than 6 ml, it is called as hyperspermia. Okay. Now to understand how does this volume come, or how do I get this, let's say 1.5, 1.6, 2 ml, how do I get it? So there are multiple contributing. The most important and the most significant factor here is going to be my seminal vesicle. A seminal vesicle gives me an alkaline fluid which is 60 to 70% of the entire volume. So it's a very significant volume and it is a majority fluid, which is why my semen is going to be alkaline. Primarily, it is going to be alkaline because this is forming a majority component of it. The next important is going to be the prostatic secretions. The prostatic secretions are going to be around 25% of the entire thing. Now, these prostatic secretions are going to be acidic. So basically, a combination of these two ensures that it is being maintained in the slightly alkaline range, but it is always going to be alkaline because this is still becoming the majority part. Apart from that, the bulbourethral glands have some role and they secrete around 5% of the semen volume. And lastly, I also have epididymal because they are staying there for 15 days. So epididymis is also giving its contribution. Epididymal secretion, not volume, secretions, which is minimal, less than 5%, but it is present. I will tell that in the end of the session, give what is that exact thing that comes from the epididymis. So these are the majority secretions. What is the clinical significance of it? Assume that I have a patient with hypospermia. What does hypospermia mean? Of course, less than 1.4 ml. What does it mean and what do I do next? So the first thing that I'll do is I'll check pH. Once I see that it is less in volume, I'll be checking the pH. If the pH is acidic, it means that the prostatic secretions are now becoming the primary contributor. If the volume is less, if it is acidic, it only means that the alkaline component that was my seminal vesicle is not secreting anything. This is possibly because of seminal vesicle aplasia, that is basically it has not formed at all, or much commoner, seminal vesicle blockage. Blockage can be because of any infection, any sexually transmitted infection with chlamydia, or let's say with gonorrhea, or there can be something more called as ejaculatory duct obstruction. Now, ejaculatory duct, what exactly is the ejaculatory duct? I'll just show you an image. I have kept an image for this itself. So you see that whenever it is coming over here, this is the seminal vesicle. Of course, the seminal vesicle, this is the duct of seminal, yeah. This is the duct of seminal vesicle, this over here. This is, of course, the vas deferens. This blue thing is the vas deferens. Now, this point where both these are meeting and forming a common tract over here, this green thing is called as the ejaculatory duct. This goes and adds into the prostatic fluids as well, and this is called as prostatic communicants. Basically, the part where the vas deferens combines with the seminal vesicle duct is the ejaculatory duct. Now imagine if there is a blockade in this seminal vesicle over here. So if there was a blockade, I'll use another color. So which color? I'll just use a yellow color. So imagine there was a blockade over here. Then obviously this would not be able to secrete anything and it is going to be primarily the prostatic secretion. That will mean it is acidic. Or what can also happen is I remove this obstruction and instead the obstruction comes over here in the ejaculatory duct. Why should ejaculatory duct get blocked? Ejaculatory duct was made up of seminal vesicle duct plus vas deferens. Either one of it goes missing, then I'm going to find a problem. Of course, I've already spoken that the seminal vesicle duct, if it is absent in case of seminal vesicle aplasia, possible. But what is that condition wherein vas deferens will be absent? The condition is going to be seen in cystic fibrosis called as congenital bilateral absence of vas deferens. Carter syndrome, primary ciliary dyskinesia, all of this is going to have CFTR gene positive, that is cystic fibrosis transmembrane receptor gene is going to be absent and or mutated rather, and that is why both the vas deferens are going to be absent. If both the vas deferens are absent, then the ejaculatory duct is going to be absent or blocked, and in that scenario as well, the seminal vesicle secretions will not be able to come inside the prostate. Hence, in these patients, you are going to get an acidic semen and also less in volume. The other end of the spectrum can be, it is going to be alkaline, hypospermia, but with alkaline pH. Now, alkaline pH means that the secretions are still coming. The seminal vesicle is absolutely normal. It is alkaline as it should be, but the volume is less. So it basically means that the volume is less because the semen is probably escaping somewhere. Because it is escaping somewhere by mistake, where can it be going? Probably because the semen was not being produced or the sperms were not being produced by the testis. So in a case of testicular failure, yes, I would agree. But again, sperms are not forming the majority thing that is giving rise to that volume. Sperms are not even responsible for volume. Then testicular failure is not going to give me hypospermia. Then what can be the reason that I'm getting hypospermia, the volume being less? Probably the container that I gave the patient was a bad quality container. It was a small narrow hole or a narrow mouth container and the semen spilled a bit. Collection error. Very likely that the collection was wrong. Or what if it escaped somewhere else? The collection was done properly. It was a proper container, but it escaped somewhere else. Where did it escape? What if there was a retrograde ejaculation? What if the semen, instead of coming down in this picture, instead of coming down, the semen, I'll show you in which color. Yeah, okay, I'll just show you in this color itself. The semen had to come down here, but instead of coming down here, it was going inside the bladder. This is called as retrograde ejaculation. Possibly. So these are the reasons in which you would know that it was alkaline. So how do you confirm retrograde ejaculation? All I have to do is post ejaculation urine analysis or urine microscopy. On microscope, you will see the visibility of sperms. They will probably be dead, but you will see it there, and that is diagnostic of retrograde ejaculation. What leads to retrograde ejaculation? It is basically the sphincter, the internal urethral sphincter is problematic. It is problematic in whom does sphincter go loose? Diabetes mellitus, long-standing diabetes mellitus, or in patients who are on sympatholytic drugs. Sympatholytic is basically beta blocker or alpha blocker kind of drug. Or if there was some retroperitoneal surgery that was done and it damaged the neural structures that were innervating the sphincter. These are the reasons which will lead to weakening of that internal urinary sphincter, and the ejaculate, instead of coming out from the urethra, is going into the urinary bladder. So retrograde ejaculation is a very important cause of hypospermia if the sorry, if the semen is already alkaline. For this, how do I diagnose? For this, it is very simple to see all of this. If it is absent or not, I'll be doing a transrectal ultrasound. TRUS. This is very important, and in a lot of centers, it is not done. So merely on looking at your, if it is acidic, we assume that it is one of these, or you do a per rectal examination of the male to see if there is any seminal vesicle inflammation or anything. But TRUS is the gold standard. So These are the causes of hypospermia wherein the volume of semen is coming out to be lesser. I have just checked the pH and have decided on the basis of the pH what might be the potential reason. What can be the reason for hyperspermia? Not too many reasons. Hyperspermia is basically you are getting excessive secretion. What are the reasons in which you can get excessive secretion? If there is inflammation. So if there is inflammation of the prostate gland or the seminal vesicle because of some ongoing sexually transmitted infection with gonorrhea or chlamydia, you are going to find that. In these patients, the most common finding is going to be in the semen, you'll see leukocytes. So it is going to be a giveaway for you to understand there's an infection. Or you can just do a truss and you will see that the inflammation, the high vascularity, enlarging size, the prostate is going to be seen, difficulty in maturation, all these signs are going to be there. Very, very, very rare. I have not seen it in my practice yet. This was about your semen volume. Since we have anyway spoken about semen volume and the pH, the next was actually pH itself as a parameter. So the normal pH usually has to be about 7.2, but as WHO now says that you have to give a normal range, the normal range is 7.2 to 8.0. Where does it come from? I've already mentioned that the seminal vesicle is giving rise to your 60 to 70%, and the seminal vesicle pH or the fluids from the seminal vesicle have a pH of 7.6 to 8.0, whereas the prostatic is also called as the acidic phosphatase that is secreted by the prostate. It is of the pH of 6.4 to 6.8. As a combination, together, they gave me a pH of 7.2 to 8.0, which was the normal range. So, what are the possible scenarios that are present over here? So, if the pH is acidic, so pH, let's say less than 7.0, plus hypospermia, which is basically reduced volume, and along with that, I also have plus minus, I may or may not have azoospermia. This is one of the possibilities that you can see. So acidic hypospermia, we have already discussed problems of the seminal vesicle, like seminal vesicle aplasia, ejaculatory duct obstruction, or congenital bilateral absence of vas deferens. Azoospermia is if it is also associated with testicular failure. If testicular failure is not there, then you will not have azoospermia. But if it is there, then you're also going to have azoospermia in these patients. What if the pH is very alkaline? The pH is more than 8.0. In that scenario, I have to understand that there is some inflammation that is ongoing, and it is very likely that it is seminal vesicleitis. So seminal vesicleitis is mainly because of chlamydia, gonorrhea, mycoplasma. All these are very important. What do I do is all I send it is for culture and sensitivity, and I treat it for prolonged antibiotics 14 to 20 days, and it will recover and come back to normal. Did everyone understand the volume and semen pH until here? Does anyone have any doubt with this very logical thinking until now? Very simple, very logical. Any doubt? Is the understanding good enough for you? Quickly tell me. I'm going as slow as possible. If you all have any doubts, ask me in the comments. I'm going to be answering them live. Also, I'm going slow so that if there is any doubt, I can solve it immediately. And I do not want to overburden you with all these logical investigations. I want you all to remember them organically. But I want a very active audience. I want you all to be answering me if you're not understanding or not. Please tell me if everything is visibly understood until now. Okay. Now comes the next parameter that is going to be liquefaction time and viscosity. Now, liquefaction time and viscosity, very nice and easy. I've already, in fact, orally, verbally described it. So, Ideally, liquefaction, just talking about liquefaction first, should be complete by 60 minutes. Whereas for viscosity, the string length or the string from pipette in which it is being held should be less than 2 centimeters. So if this was your pipette and if this was your, let's say, semen, then this drop, this string that is seen over here should be less than 2 centimeter. If this drop becomes like this too long, it will mean that the viscosity has increased. So string from the pipette has to be less than 2 centimeter and complete liquefaction has to happen within 60 minutes. If it doesn't happen by 60 minutes and you have to process it, then there is one more way of doing it, and that is can either do mechanical pipetting. So basically, mechanical pipetting is something that we do for all, in fact. It's basically, I take it, I leave it. I take it, I leave it. So basically, I'm pulling it and leaving it. So this ensures that I'm doing mechanical, you know, वो पकड़ के छोड़ रहा हूँ, I just पकड़ के छोड़ रहा हूँ. So basically, it comes in, it goes out, comes in and goes out, and hence that leads to breaking down of all the coagulum. Apart from that, you can also do chemically by adding either bromelain or chymotrypsin. You have to tell me why chymotrypsin. I'll be coming to that in a couple of minutes. What is the logic behind it? I've already mentioned that the logic behind this is I have my seminal vesicle and I have my prostate again. In my prostate and seminal vesicle, the seminogelin is something that helps in forming a coagulum. Correct? Now, this coagulum is, of course, formed to avoid damage in the acidic vagina. But it cannot always stay in the form of a coagulum, as I said, because once it enters the uterus, it has to start getting separated so that the sperms can go individually and fertilize the oocyte. So, the prostate secretes something called as a prostate specific antigen. Remember, prostate specific antigen is not responsible for making the prostatic secretions acidic. That is the acidic phosphatase. That is something else. This prostate specific antigen is a protease. What is a protease? Protease is anything that breaks proteins and peptides. These breaking of proteins and peptides is going to go and act on the coagulum and is going to break the coagulum and is basically going to help in liquefaction, natural liquefaction. Now, in the absence of this protease, or if it is less in amount, I can add something else, chymotrypsin. Remember, trypsin and chymotrypsin are your normal body enzymes. They are useful for breaking down protein in your meals into peptides and amino acids. Hence, the work of protease can also be done by chymotrypsin if it is lacking. Hence, protease is the main action of prostate-specific antigen. Now, if this cleaving of the seminogelin is not being done by these proteases, then the seminogelins will increase and the coagulum is going to stay as a coagulum. So the liquefaction is going to reduce. So what can be the reason that liquefaction failure occurs and it stays like a coagulum? The most important reason is going to be if there is a decrease in prostatic proteases, which includes your PSA. When is it going to reduce? If there is any patient who has prostatitis. Prostatitis is again infection of the prostate gland because of some STD or reduced prostate function. Why does this happen? It will happen because of age. But prostatitis is the more important cause because of the infection. It can also be very importantly because of tuberculosis. And a lot of times, leukospermia, presence of leukocytes, without any detectable culture or I mean any microbe in the culture is indicative of sterile culture is indicative of the possibility of tuberculosis or tuberculosis of the prostate or tuberculosis of your reproductive tract. Always remember that. Hence, very important to know that this liquefaction failure can lead to that. Does everyone understand this point very well? How is liquefaction occurring in my body? using prostate-specific antigen, which is the protease which goes and cleaves all the seminogenesis. Now, how do I diagnose it? Of course, I just have to send the culture and sensitivity of my semen, and then I have to treat it with antibiotics. Next, the last parameter is going to be my semen color and odor. Now, odor is something that I have never seen. Even if I'm the best embryologist in the world, if I'm the best andrologist in the world, if the world relies, I mean, if the world just blindly relies on my report, I would still not be able to, unless the odor is really bad, I wouldn't be able to tell what is a normal odor. Please, I would not be able to do that. Uh, I don't know. I mean, for people who have watched CID in the past, they had that Professor Sarunge who would even taste various things. He would taste all those samples, smell it. I wouldn't do that. Semen color, fine. Odor, I can't. But you have to know about it. So the normal semen color has to be somewhere between grayish white to yellowish white. And has to be opalescent. Opalescent is basically almost opaque. So opalescent is a better word, but opaque also is something you can understand. If it is not this, if it is watery and translucent, then you have to understand that the number of sperms are less. Remember now comes sperms. Sperms do not give rise to or lend anything to the volume side of things, but they lend color to it, they lend opacity to it. So reduced sperms, which is also called as oligospermia or azoospermia, is going to be related with your watery and translucent nature of it. Apart from that, if it is slightly more yellow, if there is a yellowish tint to it, it can either be because of jaundice or it can be because of physiological bilirubin. Why would physiological bilirubin come in it? If the abstinence period has been too long, then the bilirubin is going to accumulate in the semen as well, just like it accumulates in the urine. And whenever there is urination, and if you have not hydrated yourself enough, your urine is yellow because of physiological bilirubin. Similarly, the accumulation of semen for a long time, so increased abstinence period, you will see that males will have a slightly yellowish tint to it. A slight yellowish tint is not that significant, remember that. But if it is gradually going to green, then there is a very high chance that if it is green or if it is even cloudy, it is not white or opaque, it is cloudy. Matlab, what do I mean if this is a semen? If this was overall white, opaque, I know it is normal. But if there is a cloudy spots in it, this cloudiness is going to be called as pyospermia. And is very likely because of infection and WBCs in it. So this is because of infection. Apart from that, other color that you can have is I had a specimen that someone has sent me. I didn't find the picture though before starting the session. It can be red or pink. Red or pink is going to be indicative of hematospermia. And this hematospermia is basically because the blood has come through some source. What can that source be? It can be either a seminal vesicle stone. It can be probably because of prostatitis. Of course, you know that in any form of inflammation, there is rubor, dollar color, all of that. So rubor is redness. That redness is because of hypervascularity, and these small vessels can keep breaking down, and that can lead to blood. So prostatitis, or if there is any ejaculatory duct pathology, including malignancy. Also, bladder malignancy, the first sign can actually be hematospermia. So, what you have to do is your diagnosis should include a TRUS, that is transrectal ultrasound, plus cystoscopy. Cystoscopy so that you will see the urethra as well as your bladder properly without failing to miss out on any lesion, any pathological lesion, especially a malignant lesion. So, that is what is going to be seen in your red and pink. Apart from that, the odor they say is like bleach. Now, honestly, I have never smelled bleaching powder, and I don't even know if it has any smell. And they say that if it is odorless, then it is because of aspermia and or because of retrograde ejaculation. Please spare me, but I have never seen any odor, so I don't know. But yeah, for you to remember, odorless is a problem. They say that odorless is because of aspermia. I mean, there is just no semen. Of course, if there is no semen, then it will have no odor. But yeah, that is what they have given, or in retrograde ejaculation. So basically, whenever the sperms are lacking, azoospermia would be a better diagnosis over here. Then it is going to be odorless, but still not that significant. Significant is the color. And with this, we have discussed all the four macroscopic features: volume, you have your liquefaction, you have your pH, and of course, you have your semen color. And this is about macroscopic factors. Does anyone have any doubt with it? Quickly tell me. If not, I'll be moving on to the most important part now in the second half of a session, that is microscopic factors. Any doubts? Quickly tell me. I want maximum responses in the comments. All you have to do is comment so that I understand you all are understanding. It has to be a two-way thing. I'm taking these sessions for free just so that you all can actually interact with me live and you all can learn this topic simultaneously with me. Tell me if you all have any doubts. Now, coming to the microscopic features. Now, in microscopic features, the first is going to be a very important one and the heart of every semen analysis, and that is sperm concentration and total count. Now, before I tell you the values, or wait, I'll just tell you the values beforehand. The concentration ideally has to be more than 16 million per milliliter, and the total has to be more than or equal to 39 million per ml, or per ejaculate, not per ml, per ejaculate. Now you have to know that sperm concentration and total count is a function of two things. The first is testicular function. Why? Because the spermatogenesis happens there. So the testicular function, if there is any form of testicular failure, the spermatogenesis is going to be completely impaired. Kuch bhi ho jaye. If anything happens to the Sertoli cells, your testicular function is deranged. And the second important part over here is your patency of ductal system. So of course, if your vas deferens or if your ejaculated ducts, all of that is not patent. If there is something like congenital bilateral absence of vas deferens, then you are never going to get those sperms. So it is a combination of these two functions, and problem in each or either of them is going to give rise to a derangement of your sperm concentration. So what is it that is going to call as less sperms? So in that scenario, anything less than 5 million per ml is going to be called as severe oligozoospermia. If it is completely absent, then it is zero sperms, it is azoospermia. In either of these cases, your diagnostic tests are going to include FSH, LH. Why? Because if you have testicular failure, if for some reason your testis is not functioning, then in your testis you also have Leydig cells which will not function. Now, if the Leydig cells don't function, they will not produce testosterone. And if the testosterone is not produced, the negative feedback mechanism will kick off and FSH and LH will increase. So hypergonadotropic hypogonadism. So hypergonadotropic hypogonadism is going to be hypo is going to be reflected in the form of a testicular failure. It can be because of anything like orchitis, trauma, torsion, necrosis, anything, or just genetic deprivation of your testicular function. Not just that, I would also want to test for testosterone because it is what is produced by the Leydig cells. Inhibin is going to be checked for, and prolactin. Of course, you can check prolactin just to know if there are any external factors. You can also check TSH in this. A very important thing that you can do over here and you have to do over here is karyotyping, just to see if there are any Y chromosome micro deletions. You can also do it separately just to be able to see if it is not this premature testicular failure, just like you have premature ovarian insufficiency. If that premature ovarian insufficiency is mostly because of something like syndrome X, that is Fragile X syndrome. What if this testicular failure is because of something like that with the Y chromosome? So you have to be testing for these things whenever you have a patient with severe oligospermia or azoospermia. One more criteria can be, or one more type of low sperms can be cryptozoospermia. Crypto is hidden. So hidden because they are so low in number that you have to centrifuge. After centrifuge, you find a few semen. You find a few. You find a bit of sperms. So it is less than zero point 0.1 million per ml after centrifugation. That is cryptozoospermia, again a form of severe oligospermia. Whenever you get azoospermia, but you have normal hormone parameters, it will indicate possibility of obstructive azoospermia. Now, azoospermia is a separate session that I'm going to be taking on this month end. In that, I'm going to be discussing how is semen preparation done. How does the swim up, density gradient, all these methods mimic our natural conception, and how do they mimic the natural female genital tract. I'm going to be talking about the algorithm for azoospermia. Everything is going to be there in azoospermia. It's a completely separate topic because it is a major topic which I'll be discussing on this month end. The dates are going to be announced within a couple of days, but that is going to be exclusively for subscribers. So azoospermia and its practical management for IVF consultants is going to be taught in that session. So what if you have a scenario wherein you have high concentration? So the concentration is good, you have high count as well, but you have low motility. I'm coming to motility, but just as a question, in that scenario, I have to understand that there is some problem with the epididymis. What is the problem? I'll be coming to that. This is the most important part of the session, the function of epididymis. So epididymal dysfunction is very important as a cause of high concentration, high count, but reduced motility. Why does the motility go down if there is epididymal dysfunction? And we coming to that. If there is low concentration of sperms and there is high FSH, I've already discussed, with high LH is going to be indicative of testicular failure. Okay. Nowadays, the clinicians are preferring something called as TMSE, total motile sperm concentration. So total motile sperm concentration is a combination of the total, right, is a combination of the volume of semen into the concentration into the motility. Of course, the volume is going to be in ml. Your concentration is going to be in million per ml, and your motility is going to be in the form of a percentage. TMSE more than 20 million is said to be normal, and natural conception can be tried if everything else is normal, of course. This is assuming everything else is normal. Remember that this is just one of the ways of assessing or giving an idea of what to expect. If it is between 9 to 20 million, in that scenario, so remember I'm talking about 20 million motile sperms. So if it is between 9 to 20 million in the entire semen or in the entire semen specimen, and in that scenario, I can try IUI, but not for more than 3 to 6 cycles. If it is less than 9, between 5 to 9, then I would want to rather go ahead with ICSI. And if it is 1 to 5, then there is absolutely no doubt it is the only. In fact, it can even require donor sperm. There is a likelihood. Not just that, I have to also do sperm freezing in these patients. I have to do freezing because this can get depleted anytime soon. That the patient will be absolutely deprived of his own sperms. So this is a very important criteria to be approached. So as a consultant, what I see, I first see the total motile sperm count, then I look at the morphology, and then I go and look at the sperm DNA fragmentation. This is my practical approach to treating a patient with male infertility. I'll be talking about morphology and sperm DNA fragmentation in detail today. Next parameter is going to be my motility. Now, as I said, that motility was given in forms of three parameters in the 2010 WHO analysis, whereas in the 2021, it has been given in the form of four. So those four are A, B, C, and D. A is rapidly progressive, B is slowly progressive, C is going to be non-progressive. But remember, non-progressive means that there is some motility, but it is just not in the straight progressive direction. Whereas D is completely immotile. These two, when I combine them, A plus B, this is called as the progressive motility of the sperms. This has to be ideally more than 30%. If it is less than 30, then we call it asthenozoospermia. Asthenozoospermia is basically reduced motility. If I combine these three parameters, A plus B plus C, then I'll be calling it total motility or total motile sperms. And that should be more than 42%. So what does motility depend upon? This motility is actually dependent upon the flagella of the sperm, which contain axonyms. You must have remembered 9 plus 2, the arrangement of it. It depends on that, and it depends on the integrity of the flagellar axonome. And remember that for the motility, for me to be able to walk now, for a sperm, the female genital tract is a place that is very difficult. It's a place where the sperm can really struggle. It's a yeah, it's a difficult place to be in for the sperm, and it requires a lot of energy first to go into the acidic vagina, then to go through the cervical mucus, then through the uterus, and then through to the fallopian tube. Actually, in the uterus and in the fallopian tube, there is microvilli that can at least help it in going towards the direction. But till there, it needs a lot of energy to go through this because it is swimming. Imagine that you have been thrown in an ocean and you have been asked to go to the other end of a shore. You will be requiring your own body's energy. Similarly, the sperm requires its own energy, and that is provided by the mitochondria. This mitochondrial ATP is present in the mid piece or the neck of the female, and these mitochondria which are present in it are very, very, very crucial for the energy. How does it get this energy? It is through, you have heard of these terms, oxidative phosphorylation and glycolysis. Very interesting point over here. These mitochondria, these spermatic mitochondria, I'll be more specific, are degraded the moment they enter the oocyte. So the oocyte degrades it. Why? Because now it does not need any movement. In fact, if the sperm is still moving after it has entered inside, then it can cause damage to the oocytes cytoplasm. In fact, in ICSI, when you have a sperm like this, what we also do is using our micropipette, we give a nick over here. Basically, we press upon it and we damage the tail. Why? So that the movement stops. And once I inject it into the oocyte, that movement won't be there and it won't damage the oocyte and the embryo formation is going to be nice and good. So the oocyte is going to degrade this spermatic mitochondria and hence the baby or the embryo will only get maternal mitochondria. This is also the reason for several mitochondrial disorders that the baby inherits from the mother. You have read this in microbiology and even in in your biochemistry. So the maternal mitochondria are the only ones that the baby is going to inherit because the paternal from the sperm are degraded by the oocyte. A very nice thing to know about it. This was about the rapidly progressive, slowly progressive, and non-progressive. Basically, non-progressive is where it is not moving forward. वो उधर ही swirl कर रहा है, something like that. What about immotile ones? Whenever I have immotile sperms, I can have two doubts. Imagine we often hear that whenever there is a bear, a brown bear who comes in front of you, you have to act dead, lie dead on the street or on the jungle road. So if I have an immotile sperm, I can have two doubts. Either the sperm is dead or it is paralyzed. So basically, either it is dead or it is just alive but can't move. It is paralyzed. If it is dead, I will call this necrozoospermia. It is when more than 96% of the sperms are dead. Whereas if it is paralyzed, then what can be the potential reason? One of the potential reasons is primary ciliary dyskinesia, wherein the cilia, the flagella, is not going to be working enough because of the inheritance of this disease in Carter-Jenner syndrome. So the dynin and all the axonims that are going to be present are going to be defective in these patients, and the tail is just not going to move, but it is alive. How do I differentiate whether it is alive or not? So to differentiate between them, I need to check the membrane integrity. So basically, how would you check whether a person who's lying is dead or alive? Of course, they don't have heart, respiration, and all. You'll just pinch the skin and see. If the person responds, then of course the patient is alive. If the patient doesn't respond, the patient is dead. Similarly, I'll be checking the membrane integrity of the sperm to determine whether it is alive or not. One of the tests for doing that is hypoosmotic saline test. I'm coming to that in the next part of this discussion. Hypoosmotic saline test is what I'll come to that, don't worry. So this was about motility. You would ask me what should lead to asthenospermia, that is the reduction in the progressive motility. The most important is varicocele. So what does varicocele do is actually it increases the temperature at the level of testis, and that leads to oxidative damage to the DNA and to the cilia. That leads to immotility in them. Not just that, the cilia, the flagella can be damaged by anti-sperm antibodies as well. That will lead to a rolling movement rather than a progressive motility. And even if there is reactive oxygen species because of infections, they can also damage it. And if there is any other immune factor that can damage it. So these are the major reasons for the damage to it. I'll be coming to this hypoosmotic saline test. I'm going to be covering it in very detail. I'm going to be showing you images. I've gotten images as well for that. But has everyone understood motility and sperm concentration until here? Quickly tell me. Has everyone understood it? Okay, great. Has this session been beneficial for your understanding? Now the images are going to start. So pay attention, pay utmost attention. All the concepts are going to start here. So the next concept is of the third parameter that I'm going to be checking on is going to be sperm morphology. Now, whenever I'm going to be speaking about the sperm morphology, I'm going to use something called as Kruger's strict criteria. Earlier it was Tigerberg, now it is Kruger's strict criteria, which says that you need to have just more than 4% normal forms for the semen to be called to be declared as having normal sperm morphology. If it is less than 4, so 4, then it is called as teratozoospermia. Just like teratogenicity is teratozoospermia. If it is less than 1%, then it is severe teratozoospermia. Now, I'll show you all what this strict Kruger criteria is. So over here, you can see that this is the strict Kruger criteria. Kruger has said that everything needs to be in place perfectly for a normal sperm. So in a normal sperm, the head, this is the entire head. This is the head. This head should carry, of course, it carries the genetic material. Its length should be between 4 to 6 micrometer. Its width should be between 2.5 to 3.5. So its length and width has been described. This is your length and this is your width. Apart from that, the shape has to be completely oval. You can see that this is an oval. It should not be globular. It should not be amorphous, that is ada teda. It has to be completely oval. Apart from that, the acrosome, I'll erase this, you will see the acrosome. This acrosome has to be covering more than 50%. 40 to 65 is what they have given, but it usually is more than 50% of the area of head. So the acrosome has to cover more than that area. So basically the nucleus that is present, this is the nucleus below, has to be less than 50%. It is the minor component of the head of the sperm. Next, you have the neck region. This is the neck region. The neck should contain the mitochondria because it has energy, it creates energy. The dimension has to be, the length has to be 6 to 7, the width has to be maximum of 1 millimeter, and it has to be always at 90 degree to the long axis of the head. So long axis of the head, it is first going to be perpendicular to that. Apart from that, the tail should be having a dimension of 45 micrometer, and again it should be inserted at 90 degree to the insertion of the head. Now, what are the variations that can be seen? You see over here that they have given, these are the various problems that can arise in the sperms. You can have head defects, you can have neck and midpiece defects, you can have tail defects, you can have excess residual cytoplasm defect. Now you can see that what are the various defects. It can be a tapered, you see that it is oblong, straight, stretched out. It can be in a pyramid form, or it can be completely round. You see that there is absolutely no acrosome that is present over here. This is called as, just use a smaller pen, globozoospermia. Now, what is the reason that globozoospermia is a problem? You see that everywhere there is some nucleus, but over here there is absolutely no acrosome. The white part was, by the way, the acrosome. So, acrosome is very important because it contains something called as phospholipase C zeta. This zeta is actually written like this in Greek terms. It is something like this. I don't know really to write it properly, but it is phospholipase C zeta. This C over here stands for calcium. Why? Because it is very important when it enters and it leads to acrosome reaction after entering the oocyte. It leads to calcium influx and oscillations inside the oocyte. This is very important for the resumption of meiosis 2. Of course, you know that meiosis 2 is stuck at metaphase 2, and for that to be completed, the metaphase 2 has to resume its activity, and for that, the calcium is very, very important. If the globozoospermia is absent, this phospholipase C zeta is going to be absent, and if it is absent, then you are not going to be able to have all of this, and the meiosis is not going to resume. If the meiosis does not resume, even if you're doing ICSI for this patient, the embryo will not develop. Even if it develops, it is going to be of a poor quality. It won't progress to the blastocyst stage. It will get arrested at some point. And even if it doesn't get arrested, it is going to eventually not get implanted, or it will abort immediately because it's a poor quality embryo. Very, very important as to why is globulospermia a problem. So what can I do about globulospermia? So the problem over here is that the oocyte is not getting calcium. So what I can do is I can put this oocyte. So I can take this sperm. This sperm is going to contain the paternal DNA content. So I will take it for the DNA content. And what is lacking? An acrosome. So I can substitute the acrosome with something called as a calcium ionophore. So calcium ionophore is basically this ionophore increases the membrane permeability of oolemma. Oolemma is the cell membrane of the oocyte. It increases its permeability to calcium. This ionophore is a compound that increases it. It is going to act like a ligand. It is going to act like a transporter. You can assume that is going to increase the calcium influx inside the oocyte. This will help in the oocyte getting the calcium and resuming its meiosis. This is something that a lot of people can do for globulospermia. If you do not have the facility for this, then in that scenario, a lot of patients, if you have multiple failed inseminations, then you can just go ahead with a donor sperm. But globulospermia, this is a big problem. Another big problem can be, it can be a large, very large size head. So macrozoospermia. Macrozoospermia is basically often because of aneuploidic sperm. Next, you can have tail defects. You see the tail defects can be the tail is very short, or it is bent, or it is coiled up completely. This is again because of problems with the flagella, and all of these are going to struggle to have progressive motility. So tail defects are again important. Neck and midface defects, you can see over here, they are going to have defects in the mitochondria and ATP production. Now, there is something called as a cytoplasmic droplet. Now, what is this cytoplasmic droplet? Whenever a sperm is developing, yeah, over here you can see. So before you see this picture, this concept, whenever a sperm is developing, the Sertoli cells are a form of macrophages. They macrophagocytose the cytoplasm of sperms. It eats away all the cytoplasm. Whatever little, whatever little cytoplasm remains anyway inside it is going to be taken away by the epididymis. So whenever a sperm is leaving the testis, it is going to still have a bit of residual cytoplasm, which is going to look like this. You see over here, look like this. Instead, see the sperms over here. These are all mature sperms, but you can see that there is no such cytoplasmic droplet. So this is going to be a proximal cytoplasmic droplet. Now, whenever the cytoplasmic droplet is going to be proximal, once it enters the epididymis, this is after entering the epididymis, this was while exiting the testis. This is going to be pushed distally. It is going to be pushed distally till here, and eventually it is going to be extruded out. This cytoplasmic residue is going to be extruded out. Finally, you will get a sperm which does not have a cytoplasmic residue. Now, if you see this over here in any of the sperms, it should mean that it has not entered the epididymis, or the epididymis has not done its function of extruding it out or putting it distally. If you find it in this distal position, then that would mean that the semen or the sperm has entered the epididymis and it has done a partial job, but still it has done some job. For me, this cytoplasmic residue is not important. It is rather an indicator of the epididymal function. And the epididymal function is one of this is the function, but the major function is to act on the head of the sperm and to cause maturation of it. Hence, this is acting as a surrogate marker. Surrogate marker is basically an alternative marker to tell me how good is the epididymal function. If it is good, either the cytoplasmic residue is not going to be seen, or it is going to be completely, it is not going to be seen, or it is going to be kept here distally. But if it is there here proximally, if it's stuck here near the neck or the head of the sperm, then it is going to be indicator of poor epididymal function, and that would also mean that the head has not received maturation from the epididymis. So this cytoplasmic droplet is very, very important. So a testicular sperm is structurally mature, but functionally it is not mature. The functional maturation takes place in the epididymis, and this cytoplasmic droplet is just one of the indicators of the state. Did everyone understand this concept? Quickly tell me, this is the concept of cytoplasmic droplet. You can see over here, you see that excessive cytoplasmic droplet over here is an indicator of an immature sperm. And that too, if it is more proximal, the more the proximity to the head, the worse is the maturation. Has everyone understood this point? Any doubts whatsoever in this? So now this was one of the beneficial actions that you saw of the epididymis on the sperm. So now I had mentioned that I'll be coming to this at some point. Let me come to it right now. So what are the various actions of epididymis on the sperm? Epididymis is like the graduation for a sperm, whereas testis was the school where it was made, jahan tak wo ja sakta tha, but epididymis is where it actually learns how to survive. So how does it learn? What all does it learn? So in the epididymis, the first thing is, I have already mentioned, cytoplasmic droplet reduction, wherein from proximal, it takes it to distal and then completely removes it. So if it is stuck in the proximal, it tells me that it's an immature sperm. If it is distal, it is mildly immature sperm. And if it is completely removed, it is a mature sperm. Although this complete removal of the cytoplasm also has a drawback, and I'll tell you about it when I talk about it in vitality. Next, it is very important. I have mentioned again and again that the motility is gained inside the epididymis for the, it is gained in the epididymis for this sperm. So what do I mean that it gains motility? So first of all, it acquires motility proteins on it. And it matlab kya? The flagella gets all these motility proteins that are fixated on it. Apart from that, ion channels are introduced. Not just this, the dynein microtubules, so dynein hota hai, you've heard about it, is one of the parts of all this flagellar system, axon and dynein, wo bhi mature hota hai. So this dynein microtubule structure, which is an integral part of the flagellar motility, matures up significantly. So all of this is very important for the motility of the sperm. Apart from that, it also achieves maturation of the membrane. So membrane maturation is obtained. What do I mean by membrane maturation? The first thing is it has increased membrane stability. So the membrane can be stable despite the acidic conditions, and it doesn't get damaged, especially of the head. This membrane stability also includes improved zona binding. So the receptors to bind to the zona pellucida also increase on it. Apart from that, there is increased oolemma interaction. So the interaction with the cell membrane of the oocyte increases. It also increases the capacity or capacitation chances. So the capacitation potential also increases over here, and increased immune tolerance or immune protection also develops over here, so that anti-sperm antibodies will not be able to destroyed completely. Not just membrane, but there is also nuclear stabilization. Nuclear stabilization, chromatin stabilization, and it makes it resistant to reactive oxygen species as much as possible. And lastly, there is increased metabolic stabilization or maturation, by which I mean that it increases the ATP production, which is very important for its future motility. So these are all the important aspects that the epididymis has for the sperm, and any damage to the epididymis, epididymal dysfunction will lead to a damage to all these things. So basically, it will lose out on its motility. The membrane maturation won't happen. So the zona binding, the zona penetration, all of that is going to be poor. The motility will be further impaired because of lack of ATP production. The nucleus is not going to be stable, so it is going to be much more susceptible to DNA fragmentation. So if the epididymis has any infection, any problem, and in that scenario, all of this is going to be affected because it spends 15 days inside the epididymis. Very, very important. Now, the next aspect is going to be that I talk about is going to be vitality. Now, vitality is its ability to be alive. That is the third factor. That is the fourth factor over here. So whenever I'm talking about the vitality of the sperm, more than 54%, earlier it was 58%, now it is 54% is said to be normal. Now, how do I know what is vitality? So vitality is whether to differentiate it is alive or dead. So to differentiate, I have multiple tests. The first test is eosin nigrosin stain. Very simply put, a dead sperm is going to be taking it up. Dead sperm is going to become pink because it takes up eosin, whereas an alive one is going to actively resist being colored. So it will stay white. So to show you all an example over here, you see over here, this pink color, this is the eosin nigrosin test for vitality. You see that this pink colored is a dead sperm, whereas this white, which resisted getting colored, is an alive sperm. So this is basically the staining that has been taken up is going to tell me. In this, I'm going to check the total percentage of sperms that are alive, and that gives me the vitality value. Another way of measuring and what we actually do in our labs is cause, that is hypoosmotic saline test. You will tell me in the comments what is the percentage of hypoosmotic saline that we use. So in hypoosmotic saline test, what we do is it is the reverse of eosin nigrosin. So an alive sperm will have its membrane receptors for water present, whereas dead would have no receptors that would be alive. So whenever you put it in hypoosmotic saline, the alive sperm is going to take up that hypoosmotic saline and it is going to swell up. Not just swelling up, the head swells and the tail curls, whereas the dead sperms are just not affected. So over here you can see that the dead sperms, you see that this was swollen. Again, this is swollen. And I can also see that the tails are curling up. You see that the tails are curling up after it has swollen. Whereas the dead ones, you see the dead ones over here, the ones that have not taken up anything, they have a very straight tail. There is no curling up anything. Whereas the ones that have gotten swollen, the heads have been swollen with saline, their tails have also gotten curled up. This is very classical of very classical of the hypoosmotic saline test. So these are the two major tests that we do. Now, one thing that you need to know whenever there is a talk on vitality. What can lead to a live sperm to die? So why would a sperm die? So basically, why do necrospermia or why should it happen? But this usually happens because of reactive oxygen species damage. Reactive oxygen species are basically free radicals of oxygen damaging the uh, that are damaging the sperm. How does that happen? So now remember that when your sperm was becoming very compact because of the loss of cytoplasm that was happening in the testis as well as in the epididymis, that was a good thing. It became very compact. But the cytoplasm contained a lot of antioxidant mechanisms. A lot of antioxidant mechanisms were there, and all these antioxidant mechanisms were lost as the cytoplasm was being lost. Not just this, the cytoplasm also carried a lot of DNA repairing mechanisms. The DNA mechanisms that the damaged DNA repairing mechanisms were also lost along with the cytoplasm. So basically, the sperm became more susceptible to reactive oxygen species damage plus the inability for its DNA to repair. To compensate for that, the epididymis made its membrane much more stable so that the oxidative species don't enter it. It also made the nucleus, I mentioned the nuclear and chromatin materials also made much more resistant to damage. That is something that it tried to do. But still, if the reactive oxygen species stayed there for a long time, and these reactive oxygen species are going to be present in a lot of fluids, and especially they are going to be present in leukocytes. So these leukocytes will have peroxisomes. These peroxisomes are going to release reactive oxygen species. And if these leukocytes are there in the epididymis, in the form of epididymitis, if there is an infection of the epididymis, in this scenario, the presence of these leukocytes will increase the reactive oxygen species. And if the abstinence is too long, then the epididymis, these reactive oxygen species will instead start killing these sperms. So basically, prolonged abstinence is going to be a damaging thing. These reactive oxygen species are also going to damage the mitochondria. So the mitochondria will be damaged. The membrane will be damaged. Hence, the epididymis is a storehouse of a lot of reaction or reactive oxygen species as well. Now you would ask me then, why do they exist over there? Remember that these reactive oxygen species have one good role to play. The good role to play is that they activate the membrane of the head. They activate it so that once it reaches, the sperm reaches the oocyte, it will be able to penetrate it and it will be able to get activated completely inside the egg. Hence, the few reactive oxygen species are necessary. But if the sperm is staying there for too long, it is like kharab sangat hai uski and it will get damaged. That is also why we say that excessive dosing of antioxidants, bahar se jo antioxidant drugs lete hai patients, if you give it excess mein, then the excessive antioxidants are going to cause reductive damage because excess antioxidation is reduction. Reductive damage to the sperm because of the depletion of these reactive oxygen species completely. So you do not have to deplete it completely also. You have to give it in doses so that some reactive oxygen species are maintained to activate the membrane. So this is a very important concept and you have to remember once the membrane is damaged, if the membrane is going to be damaged, then that is going to reduce your vitality. If the mitochondria is damaged, your motility will go down. So your motility is damaged, your vitality is damaged, and hence accumulation of sperms in the epididymis for a long time is a problem. So what we do in this scenario, whenever we are seeing patients with low vitality, low motility, we directly go and take testicular sperms. So testicular sperms are removed through TESI, that is testicular sperm extraction, or percutaneous extraction of sperms. So either you put in a needle and you aspirate it, or you can just put in not a needle, but you can just open it with a knife, and then with the forceps you can pull out a few seminiferous vesicles or seminiferous tubules, and from that you can, under a microscope, extract sperms. This is basically for it to avoid going under the epididymis. You would say, but if it is not going to the epididymis, then the maturation is not going to take place. I completely agree. That is why, because the maturation is not taking place, it is not obtaining optimal motility. That is the reason these sperms that are obtained cannot be used for IUI. They have to be used for ICSI, wherein I'm spoon feeding the oocyte with the sperm. It does not need to have any motility. It does not need to have anything else. Yes, the success rate is going to be lesser because the activation and everything, nuclear maturation is everything is pending. Hence, the results with TESI and PESI are going to be poor. But it is still better than not having any sperm at all or having all dead sperms. This is still a better option so that the person can still conceive with his own sperms and not take a donor sperm. I hope you all understood this concept. Is there any doubt in the understanding of this concept of reactive oxygen species, epididymis, and how this reactive oxygen species can be counterproductive as well as productive for the sperm's development? There is one more method, by the way. There is one more method that is there for checking of the sperm motility apart from vitality, apart from HOS and eosin nigrosin. The third is going to be laser assisted sperm selection. What we do is a tiny laser is taken and it is fired onto the semen, onto the sperm. So a small ray is fired onto the tail. This tail, if it doesn't move, no movement, it is going to be a dead sperm. Whereas if it curls or twitches, it is going to be a vital and alive sperm. So, did everyone understand all of this? The treatment for any patient who is coming to you with reduced motility, reduced vitality, the best treatment is going to be to go ahead with TESI or PISA. Not PESI, PISA था वो, percutaneous aspiration, percutaneous sperm aspiration. So either of these two is going to be done, and then of course I have to be doing ICSI with these patients. It is going to basically help me bypass the epididymis. So the last parameter under the microscopic part is going to be leukocytosis. Now for leukocytosis and also sperm antibodies, which are occasionally considered significant, WBC should be less than 1 million per ml. That is normal. If it is more than that, then it is called as leukocytosis or leukocytopermia. Where do they originate from? They originate from infection in any of the following places. It can be in the prostate, it can be in the seminal vesicle, it can be in the epididymis, it can also be in the urethra. To diagnose it, what I have to do is I have to take the semen, I have to do culture sensitivity, and along with that, also do urine culture sensitivity because a lot of times the semen might be carrying the infection from the urine. So make sure that you're checking both, and if they both show the same microbe, then understand that that was the cause of the leukocytosis. These are the places from where it can arise. These leukocytes rather, as I mentioned before, they release these reactive oxygen species through peroxisomes. What do these reactive oxygen species do? First, they do lipid oxidation or peroxidation. This lipid is going to affect the phospholipid bilayer, which is present in the cell membrane. So membranes of sperm are going to be damaged. Apart from that, it is also going to go and directly attack the DNA, which will lead to increased DNA fragmentation. Not just this, it will also lead to mitochondrial injury. So if there is lipid oxidation and if there is a damage in the the membrane of the sperm, that will lead to reduced zona binding and hence reduced fertilization. If there is sperm DNA fragmentation, that will lead to poor quality embryos. If there is mitochondrial damage, then there is going to be less ATP. If there is less ATP, that is going to result in the formation or in the occurrence of or in the loss of motility because it will not be able to move. So that is the reason why leukocytosis is a serious thing that needs to be treated because it will eventually lead to loss of fertilization outcomes, poor quality embryos even if the fertilization happens, and also loss of motility. Treat it with antibiotics. Make sure that you're not over treating with antioxidants. You would say that all these reactive oxygen species, if I over treat with antioxidants, will it help? No. Treat the cause of these reactive oxygen species. Once you treat the cause, you don't need to be worried about the cause of this reactive oxygen species. Don't over treat with antioxidants because that will lead to reductive damage. Excessive antioxidation is reduction. This reductive damage is also problematic because, as I said, that they require those few reactive oxygen species for their helping with capacitation, membrane activation, and acrosome reaction. Now, next is anti-sperm antibodies. These anti-sperm antibodies can be of various types, IgA, IgM, and IgG. And there are a few tests which you will be doing. Now, what leads to the formation of these antibodies? The most important is a break in the blood testis barrier. So if there is a break in it because of any reason, it can be torsion, it can be trauma, it can be a biopsy, it can be an infection, it can be any of these reasons, even, yeah, most importantly, vasectomy reversal. All these are the major reasons why the blood testis barrier is going to be deranged. Now, these antibodies block capacitation of the sperms. They not just do that, they are also going to affect the zona binding because they are affecting the head of the sperm. So basically, if this was your sperm, they can either attack your head, they can also attack your neck, or they can attack your tail. If they attack your head, then it is of course going to affect your capacitation and zona binding. If it attacks your tail, it is going to damage your motility. How do I know about it? There are multiple tests. The first test is mixed agglutination, or rather mixed antiglobulin test. Mixed antiglobulin reaction test, which is also called as a MAR test. What it does is, in the semen that potentially contains these antibodies, this is the semen that has antibodies in it, I'll be sending in an antibody. Just like Coombs test, I'm going to send it inside. If it coats this semen, if it coats the sperms, I will be seeing it under the microscope. And if I can see it being coated, then I would know that these antibodies are present in this patient. The other way of testing the same thing is immunobead test. So in this immunobead test, it will specifically go and bind to either the head, the midpiece, or the neck, or the tail. And it will also tell me whether it is IgA, IgM, or IgG. Remember that IgA is going to have the worst fertility outcomes. So it will give me a much more specific outcome and will tell me the exact part where it is going and affecting. How do I manage this? Anti-sperm antibodies, the most important thing is the brain barrier the blood testis barrier has been deranged. So abstinence is very important, first thing. Secondly, testing again can be a very important way of getting a good quality sperm. And if still nothing is working, then what is it affecting? It is affecting the motility primarily because of this motility is being affected primarily. It is also affecting the poor, it is increasing the DNA fragmentation. So it is affecting the DNA fragmentation. See, So zona binding, if it is affected, and the motility, if it is affected, I can treat both of these by just doing ICSI. I can just take the sperm and I can inject it inside the oocyte. But for the DNA fragmentation, I need to do a few tests that are called as sperm DNA fragmentation test to know how damaged the sperm is. Because if the DNA fragmentation is normal, then not the loss of zona binding and mobility can be overcome. But DNA fragmentation cannot be overcome. So I'll be doing sperm DNA fragmentation testing. So what are the tests for sperm DNA fragmentation? So sperm DNA fragmentation is basically of two types. You can either have single strand break or double strand break. So basically you have your DNA like this. You can have damage to either one strand, can have single strand break, which can still be repaired by the oocyte, or you can have double strand break, which will not be repaired by the oocyte. In both the scenarios, you will be expressing this in the form of a DNA fragmentation index. It's a percentage. Less than 15% is normal, more than 30% is abnormal, in between them is intermediate. If it is more than 30%, then I have to go ahead with DNA fragmentation. If it is too high, then I have to go ahead with sperms. What is leading to this damage of DNA? It is the reactive oxygen species, which is the place where maximum reactive oxygen species damage is occurring. It is occurring in the epididymis. So I have to bypass the epididymis and I'll go directly extract the sperms from the testis. I can also ask these patients to correct the cause. If it's an infection, I'll treat them with antibiotics and I'll call them 2 to 3 months later. And then I'll retest them and I'll see the DNA fragmentation. Do not overload these patients with antioxidants. No amount of evidence has shown that it has helped much. What are the various tests that I can do to determine this? There are various tests. The first is tunnel assay. The full form of tunnel is something that even I don't remember. It is terminal deoxynucleotidyl transferase. Very difficult to remember. Next is SC-SA assay, that is sperm chromatin structure assay. Then is your halo test or halo sperm test. Very important. In this halo sperm test, what we do is we do a little, we have two options. We have intact DNA, which is normal, or we have damaged DNA. What we do is we add this DNA or this cement to agarose gel and we add a mild acid to it. On adding this mild acid, denaturation will start and this denaturation will start unfolding the DNA. This unfolding will be normal unfolding and complete, beautiful unfolding like a flower will happen in intact sperm. Whereas in a broken one, this unfolding would be ugly or it will just not happen. So no unfolding will be seen in a damaged DNA. So if you see over here, I've shown a picture. You see that this has beautifully come up like a flower. You see, very nicely happening. Compare this with something like this, nothing over here. You see that all the places where A has been returned are all the beautifully dispersed sperms. You see, these are all the good quality sperms, whereas wherever they have mentioned C, you see that C is all of these poor quality sperms. So over here, this one is the place where it has completely opened up and is the normal sperm. Whereas the place, so basically this is forming a halo. You see that this is the sperm and this is the halo that is forming around it. So this region is called as a halo around it. So wherever there is no halo, वो हेलो इज बेसिकली जो बुद्धा के सर के पीछे आता है, गौतम बुद्धा के पीछे. नो हेलो इज अ पुअर क्वालिटी sperm with DNA damage. Whereas the one with a good halo is a normal and a good quality sperm. This is how you will be doing a halo test. Very important and the most important test that we do. Apart from that, you nowadays also have Comet test that a lot of people are doing, but you need to remember this Hallosperm test, Hallo test, which has been done for DNA fragmentation index. So these are all the major tests that we do for knowing about the semen. Now, what are the minor tests that we do? Few of the minor tests and the rarely used tests include tests for seminal vesicle, few for epididymis, and few for the prostate. Rarely done, theoretical importance. For seminal vesicle, there is something in the seminal vesicle that I have not discussed yet, is fructose. Now, this has been defined by the WHO 2021 guidelines, which is why I'm discussing. So, it says that fructose concentration should be more than or equal to 13 micromole per ejaculate. It says that if this reduces, there is a reduction in the fructose content, it is indicative of seminal vesicle aplasia or ejaculatory duct dysfunction or ejaculatory duct obstruction or congenital bilateral absence of vas deferens. The same thing is the reason why your semen is going to be acidic. For epididymis, I have a marker called as neutral alpha glucosidase. Now, this neutral alpha glucosidase is going to be seen normally uh, more than it is going to be milliunits per ejaculate, 20 milliunits per ejaculate. If this is less, then you will know that it is because of an epididymal block. Again, not often done. And lastly, for prostate, you have two important things. Now, prostate contains two important things, and that is citric acid and zinc. Now, citric acid, the concentration that has to be present is more than 52 micromole per ejaculate, and zinc has to be in more than 2.4 micromole per ejaculate. The reduction in both of these is going to be indicative of some damage to the prostate, like prostatitis. If this reduces, then you would know that it is because of prostatitis. So now, combining all of these that we have seen, I have finally gotten a summary of the session today. So, if I have all normal parameters, then in that scenario, the total motile sperm count has to be more than 20, the morphology has to be more than 4%, the sperm DNA fragmentation has to be 15%, and in that scenario, I can recommend 3 to 6 cycles of IUI. Also, female factor assessment is more important here. In cases of mild oligoasthenozoospermia, so oligo is basically reduced count, astheno is reduced motility, and so motility, and that is going to be reduced. So over here you can see that the total motile count is less than 10. The morphology is between 2 to 4. So you would also want to call it teratospermia. From DNA fragmentation is slightly high. IUI can be done, but not for more than 2 to 3 cycles. Also give antioxidants to the patient. Moderate OAT is oligoasthenoteratospermia. So the count is low, the morphology is poor, the sperm DNA fragmentation is bad. And as I said that I'm going to be assessing 3 parameters as an IVF consultant in all the patients. The recommendation for these patients is going to be ICSI only. Similarly, for severe OATs, it is going to be ICSI mandatorily. In fact, in severe OAT, you can even need a donor sperm. And plus, you have to freeze the extra sperm on the day of OPU because you may not get it in the next time. Apart from that, for azoospermia, non-obstructive, obstructive, I'm going to be talking about this in the next session. Globulospermia is total motile sperm count less than 5 million, absolutely no acrosome. ICSI plus calcium ionophore is the management, but overall the prognosis is poor and you will have to consider donor sperm eventually. If it is severe teratospermia, again, you have to check for azoospermia. I'm going to be talking about this later. If it is leukocytospermia with OATS, in that scenario, you have to first treat it and then you have to consider ICSI. Finally, if the anti-sperm antibody is present, then directly go ahead with ICSI and also check for the sperm DNA fragmentation. Treat the sperm DNA fragmentation because even if you do ICSI, your embryo might be of poor quality, which will not, have great outcomes. So treat it first, then get good quality embryos, and then they will implant as well. And with that, I finish with my today's session on male infertility. I hope you all like this session. We discussed about all the macroscopic parameters, all the microscopic parameters, how the epididymis helps in the development, and how it helps in the maturation, how overstay inside the epididymis is a problem, how lesser stay is a problem, how reactive oxygen species are helpful in some concentration, but in excessive concentration lead to damage to the DNA, mitochondria, membrane, everything. Everything covered. This is the final list. Take a screenshot of this. You have to remember this. Fine, you can. But if you remember the logic behind everything, then it is going to be much easier for you. I hope you all understood this session and I hope you all liked it. Please do comment if you all liked it. I would love a feedback. Thank you so much and keep watching Conceptual, and I'll see you back next month with yet another such free session.